Thanks very much for the eloquent introduction and for the opportunity to present my talk at the Innovations conference here. And hopefully you'll find some of the things I'm about to present innovative. I'm just trying to figure out how this works. All right.
Apologies, stand by just for one moment, please.
Sorry, just trying to figure out how this works, but okay, sounds good. All right, here you go. All right, there you go. So I'll be talking to you about the secondary stroke prevention after ICH and if it's time for a paradigm shift. And these are my relevant disclosures. So I'd like to make three hopefully compelling arguments. The first of which is that intracerebral hemorrhage or ICH is in fact associated with an increased risk of major ischemic cardiovascular events down the road. The second argument is that ICH is actually associated with covert brain infarction or silent brain infarction, as we call it. And third, that some of the proven secondary stroke prevention strategies that we have currently in place, like antiplatelets, statin medications, are in fact safe and maybe even potentially efficacious in patients who have an ICH. And where do we go with this potentially exciting new information? So just to give you a little bit of background, we've all been told that the incidence of ICH is about 70,000 to 80,000 patients in the US alone, and almost 3 million worldwide new cases. We've also been told that the mortality is still pretty high. 30% of the patients die in the first 30 days, and nearly 50% or half of all patients have poor outcomes. However, we do have a lot of exciting emerging data that have suggested that nearly half of all ICH patients who are deemed to have severe disability, even at the 1 month stage, end up having favorable outcomes at the 1 year mark. And so clearly, we now know that ICH patients require a lot more time to recover and rehabilitate compared to patients who have an ischemic stroke or maybe even a subarachnoid hemorrhage. And we also know that 1 in 4 ICH patients who end up having mild disability early on eventually do end up having significant functional decline. And a large part of that is mainly because of recurrent stroke. Now, a rather disturbing statistic was published recently where they looked at the national trends in the incidence of ICH. And as you can see in the purple arrow, that's the trend that represents the non-Hispanic Black population. And clearly the incidence is extremely high. It's also pretty high in the Hispanic population. But if you look at the screen to your right, you can see that not only is the incidence increasing, it's actually increasing in patients who are relatively young, between 18 and 44 years of age and 44 and 65 years of age, which is a major shift in how the ICH statistics have been described before. So let's look at ischemic conditions in general. We deal with ischemic stroke and myocardial infarction. We know that the two are actually associated with each other, and they're actually a risk factor for each other. But ICH also happens to share the same set of risk factors with both ischemic stroke and MI. Despite these statistics, we still somehow have the old paradigm where we look at an ischemic event and assume that the patient is at a risk for further ischemic events in future. And similarly, that ICH begets another hemorrhagic event like an ICH. So with that, I'd like to make my first argument that ICH is actually associated with an increased risk of major ischemic events. So if you look at case series, you'll see that the rates of ischemic stroke vary anywhere between 3 and 6%. And you could argue that a fifth of all ICH patients have atrial fibrillation, which is by far the most significant risk factor for these ischemic events. But if you look more closely, the CHA2DS2 score in most of these ICH patients is usually 2 or above, and that corresponds to an annual stroke risk of about maybe 2 to 3%. But the ICH patients with the same set of risk factors have a much higher risk of stroke. It's as high as 8 to 10%. So clearly there are more factors here at play. In this epidemiological study out of Denmark, the author showed that the cumulative rates of a major vascular event, which is recurrent stroke, MI, or cardiovascular death after ICH, is almost as high as 15% in the elderly population at the end of the 1 year mark, regardless of men or women. And this rate significantly and proportionately goes up as we look at the different time trends between 2 and the 10-year mark, and going almost as high as 40%. In another study, which was done in China, where they looked at 500,000 patients in a population study, you can see that the risk of recurrent stroke was highest in patients who survived an ICH in the red line on the left side, and compared that with ischemic stroke or subarachnoid hemorrhage, which were significantly lower. And similarly, the graph on the right also shows that patients with ICH have the highest potential risk of a major vascular event, and this is the 5-year cumulative trends. So we did a study where we pooled data from 4 different NIH cohorts, and in about 50,000 participants, we observed that patients who had an ICH had a 2.5-fold increased risk of a major vascular event. And this was a composite of ischemic stroke and MI, and the rate was almost 4 to 4.5% compared to 1% in the general population. When we looked at ischemic stroke and MI separately, we found that patients with an ICH had an increased risk of both ischemic stroke, which was 3-fold higher, and MI, which was 2-fold higher. And this was regardless of all the risk factors, different age groups, and whether patients were on antiplatelet or anticoagulation. We also replicated the study in another data set, which was among 1.8 million Medicare beneficiaries. We saw that there was still a significantly increased risk of stroke and MI in ICH survivors. And what was striking was that the hazard ratios of the risk was significantly higher in the first 6 months, almost as high as 7-fold in the first month after ICH. So what about the risks with different locations of the ICH? Now, all ICHs are not the same, obviously. So we know that lobar and deep hemorrhages behave differently. And in this large population study that was done in the UK, what they found was that patients who had a lobar hemorrhage ended up having a much higher risk of recurrent ICH as compared to the statistic on the bottom, where deep ICHs were more likely to result in major cardiovascular events. They also looked at patients with ICH with and without AFib. And interestingly, though, regardless of the presence of AFib, both had similar rates of recurrent ICH. But when you look at ischemic stroke, as expected, AFib patients had much higher risk of stroke. But when you see the risk of the serious vascular events, even in patients who don't have AFib, the risk is pretty significantly high. And finally, you can see that in this particular study out of France, where they looked at lobar and deep ICHs and how patients fare in terms of major vascular events or recurrent ICH, it's very striking that major vascular events were significantly higher, almost 7.3% per year in patients who had a deep ICH, compared to about 3.5% in patients who had a lobar. Conversely, patients who had a lobar hemorrhage, not surprisingly, had a significantly higher risk of recurrent ICH. So where do we go with this information? So the new paradigm that seems to be appearing is that lobar hemorrhage increases your risk of recurrent ICH more so than arterial ischemic events, while a non-lobar or a deep ICH increases your risk of arterial ischemic events more so than the risk of a recurrent ICH. And so perhaps our hypothesis should be that non-lobar or deep ICHs behave very similar to lacunar strokes and should therefore be treated with similar interventions. What about ICH and silent or covert brain infarction? Now, we get MRIs in patients who have ICHs all the time. We see that these diffusion positive hits, or DWI lesions, as we call them, are pretty common, as common as almost 30 to 40% in the acute phase of the ICH. And these lesions can be right next to or around the hematoma, where they're called perihematomal lesions, or removed from the hematoma, where they're called remote lesions. Now, the standing hypothesis is these lesions are mostly attributable to the acute blood pressure reduction that we do. We have patients presenting with systolic blood pressures in the 200s, 250s, and we acutely bring the blood pressure down to less than 140 sometimes, that can probably cause these lesions. The other two hypotheses are that there is pre-existing severe cerebral small vessel disease, and finally, some amount of hypercoagulability and potentially even microembolic phenomena. Now, in a secondary analysis of a blood pressure trial in ICH patients called the ICH ADAPT study, where patients were randomized to a systolic go less than 150 versus less than 180, the authors did a secondary study where they performed CT perfusion studies in all patients. And they looked at three different zones. One was right next to the hematoma, which was the perihematomal zone. The second was what they call as the internal border zone and the external border zone between basically looking at the watershed territories. And as it turned out, regardless of how significantly the blood pressure was reduced, there was no reduction in blood flow in any of the three zones. And in another study where the authors used a validated ADC method to define moderate to severe ischemia, they again try to correlate changes or controlling blood pressure with presence of these DWI lesions. And what they found was, regardless of how the blood pressure was controlled, either in the first 6 hours or the first 24 hours, there was absolutely no perihematomal or any perfusion deficits in patients, regardless of the blood pressure. So to understand what these punctate lesions are, we performed a meta-analysis where we combined data from 3 different randomized trials and from one of the prospective NIH studies. And we had about 1,700 patients with an ICH and MRI data. And what we found was DWI lesions were more common in patients who were younger, who had larger hematomas to begin with, and more importantly, those who had significant small vessel disease, such as microhemorrhages, like the slide on the top, and significant white matter hyperintensities. And regardless of how the blood pressure was controlled in the INTERACT-2 trials, so less than 140 or less than 180, you can still see that there is no difference in the incidence of DWI lesions. Interestingly, though, this study from China actually showed that there could be some ischemic stroke mechanisms at play that can potentially cause these DWI lesions. For instance, what they showed was that if patients had large artery stenosis, then the DWI lesions tended to be much larger than 1.5 centimeters, while those who had small vessel disease had significantly smaller DWI lesions. So perhaps we are missing a trick or two by not paying attention to any potential stroke mechanisms that are at play. Now, what we do know is these DWI lesions are obviously not benign. They're associated with worse mortality and functional outcomes. We also know that these DWI lesions, in fact, are associated with an increased risk of recurrent stroke down the road. And we have shown that the risk of recurrent stroke after DWI lesions is almost 7% absolute increase. So what this means is that ICH increases your risk of clinically overt and clinically silent ischemic events in the brain. The emerging data seem to suggest that perhaps this risk is higher in patients who have a deep or a non-lobar ICH. And this risk persists regardless of whether patients have AFib. So what about potential secondary stroke prevention strategies in these patients? Now, the current guidelines, if you look at AHA, NCS, or the ESO guidelines, they sort of equivocate about the use of secondary stroke prevention strategies, particularly antithrombotics or lipid-lowering strategies, because they are all perceived to have an increased risk of ICH. So the focus is mainly on ICH, prevention of recurrence of ICH, which is essentially blood pressure control. Now, we know blood pressure control is very important, and history has taught us that. We all know the 3 gentlemen in this picture don't need any introduction. This was at the conclusion of World War II at the Yalta Conference in 1945. And FDR apparently was looking extremely pale, only to be examined by Churchill's personal physician and was found to have a systolic blood pressure of 260 over 150 and ended up dying from a fatal hemorrhage 3 months later. Stalin, on the other hand, also suffered from long-standing hypertension and ended up dying in 1953, if I'm not mistaken, also from a fatal ICH. And Winston Churchill ended up having several strokes and eventually died from one of the strokes. So clearly, blood pressure is the way to go if history has taught us anything. Unfortunately, in the secondary stroke prevention world, this is not as easily implementable as we think. So let's look at another option, which is to look at the combined efficacy of antiplatelet and lipid lowering strategies. So aspirin and statin, for instance. Now we know that the combined efficacy is about 0.7 hazard ratio, which translates to a 30% risk reduction. So if you combine these two medicines, then you decrease the risk of secondary cardiovascular disease by almost 30%, based on meta-analysis, the Picasso trial, and even in primary prevention trials like the TIPS-3 trial. So maybe we should be using these in ICH survivors. Unfortunately, all the data that we have today, the ICH patients were excluded. So let's look at antiplatelet therapy. Now, if patients were on antiplatelet therapy and end up having an ICH, there is compelling data now to suggest that pre-morbid use of antiplatelet therapy is actually not associated with hematoma expansion or, in fact, worse outcomes after the ICH. What we do know, though, is the pre-morbid use of antiplatelet therapy may actually impact the initial volume of blood or initial hematoma volume on the CAT scan. And that is more so in lobar hemorrhage patients and not so much in deep hemorrhage patients. Now, what about considering antiplatelet therapy right after an ICH? So this was a meta-analysis of two very, very old stroke studies called CAST and IST, where patients were given aspirin purely based on the clinical symptomatology, so even before CAT scans were done. And when the authors looked back and saw that a subset of patients actually ended up having an ICH to begin with and got aspirin, they went back and did the analysis and found that aspirin was not associated with increased mortality, even in the hyperacute phase. But the more convincing data in this aspect is from the RESTART trial, where about 500 odd patients were randomized who had an ICH and were previously on an antiplatelet therapy, were randomized to either restart antiplatelet therapy or stay off of it completely. And the primary outcome was risk of recurrent ICH. And interestingly, what the study showed was that patients who were restarted on antiplatelet therapy had almost a near 50% reduction in the risk of recurrent ICH, which was counterintuitive. So maybe antiplatelet therapy is in fact protective in these patients. Now, what about statin therapy? Now, statin therapy obviously is the big elephant in the room, but if you look at using statins after some 30% risk reduction as far as secondary stroke outcomes were concerned, and that included recurrent stroke, MI, and mortality. And there was a meta-analysis that also showed that in fact statins after ICH can improve mortality and also improve functional outcomes. So maybe there is some benefit there. But what about the risk of statins? Now, we all know that after the SPARKLE trial, which showed a potential risk of ICH with statin therapy, there is a divided opinion, and this is a highly debated and contested topic. But there was a large meta-analysis that showed that there was absolutely no increased risk. And to your right, you'll see that there was another meta-analysis that came out very recently, and that seemed to suggest that statin use was actually maybe, in fact, associated with an increased risk of ICH. But the number treated to harm was almost 250 compared to the number treated to decrease cardiovascular risk, which was 35. And in another analysis where they looked specifically at patients who presented with an ischemic stroke, there was absolutely no increased risk of ICH. So we also do know that the location of the bleed seems to be associated with statin use. And in this study, they showed that patients who were more likely to have a lobar ICH had statin use. And that obviously we know is the basis for the SATURN clinical trial, which is an ongoing NIH trial looking at the safety and efficacy of statins in lobar ICH patients. So at this point, I think it is safe to assume that our observational data so far suggests that maybe antiplatelet therapy is safe and even potentially efficacious, and that statin therapy is safe and efficacious at least after a deep ICH. So we find something new. Hopefully everyone's getting excited. And how do we help our patients with this? So perhaps it's now time to plan a randomized clinical trial. So with that in mind, we proposed this to the NIH called the Optima, and it stands for optimal prevention of thrombosis after intracerebral hemorrhage with intensive medical therapy and antiplatelet medications. I'm joined in this endeavor by Dr. Wendy Zia from Hopkins, Kevin Sheth from Yale, and Ralph Sacco from the University of Miami. And we are proposing Optima as a multi-center prospective randomized clinical trial, which is placebo-controlled as well. We hope to enroll patients who have a non-lobar ICH, no known prior AFib, and no immediate indication for either statin or antiplatelet therapy. And the intervention arm is very simple. It's a fixed dose of aspirin, so low dose aspirin, 81 milligrams, and atorvastatin or Lipitor, 40 milligrams, and the other arm gets the placebos. Our main aim is to show that a combination of aspirin and statin actually results in a significant reduction in your risk of recurrent stroke, MI, or cardiovascular death. And the secondary aim is to show that a combination of aspirin and statin does not increase your risk for recurrent ICH. So very simply put, the inclusion criteria in a nutshell are spontaneous non-lobar ICH, which is going to be defined as hemorrhage within the basal ganglia, the internal external capsule, thalamus, brainstem, or cerebellum, and no known AFib in patients who are over 18 years of age. And the exclusion criteria are pretty standard to all ICH trials. So the study design is, this is a secondary stroke prevention trial. So patients will be enrolled even after discharge, potentially, hopefully within 45 days after ICH onset. And the two interventions will be performed in a double-blinded randomized design. And patients will be followed every 3 months for the first 1 year, and then after that, every 6 months thereafter. So I already described this. And all the statistical considerations point to the fact that we will end up needing 1,606 patients with a deep ICH in the trial. So the trial will hopefully be recruiting patients from the US, Canada, and also 10 different international countries, including 100 international sites. And what we hope with this trial is that hopefully we can find a better answer for secondary stroke prevention trial, prevention after ICH. And perhaps this could be a major paradigm shift where currently if you have a patient with a lacunar stroke, you start aspirin and statin without batting an eyelid. But maybe it's the same approach that needs to be done for a patient who presents with a non-lobar or a deep ICH. And given the fact that deep ICHs tend to involve or affect the minority populations, it also aligns with the NIH's priority goals. So to summarize, hopefully I've convinced you by now that ICH survivors face a heightened risk of major adverse cardiovascular events, and ICH patients can also have silent or covert brain infarctions, that we are in dire need for better secondary stroke prevention strategies in ICH survivors, and perhaps the need of the hour is a randomized clinical trial. So I'd like to acknowledge and thank all my collaborators, and I'm happy to take any questions.
Hey, Sanju, thank you. Excellent talk. 2 questions, man. So since you showed that 40% of the ICH can have ischemic strokes, so let's say you have a 50-year-old gentleman with some LVH, they have a deep lower hemorrhage. What would be a trigger for you to start thinking, does this patient maybe have vasculitis or something else going on? Like, what's your threshold? How many DBI do you tolerate before start thinking outside the box?
Yeah, no, that's a great question. I mean, I think obviously LVH is one indication for underlying long-standing hypertension, right? At this point, we actually did a survey to get a sense of what the current practices are for secondary stroke prevention after ICH. We sent out a survey to all the StrokeNet investigators. And as it turned out, what was very striking was there are some centers in the US where any patient with a deep ICH automatically gets started on aspirin regardless. Like centers like MGH and Hopkins, they openly do this all the time. Our stroke colleagues have also started increasingly doing that. But obviously there is no data to support any potential benefit, at least without a randomized clinical trial. But you know, if the data is anything to go by, hopefully we'll have answers in the next few years.
And with the placebo arm in our study, you're not going to give them any aspirin. I mean, what are
Right.
the practices to start
Because
aspirin within 3 days?
the placebo arm will be in accordance with the current AHA or standard current guidelines, which if you have no prior indication or you were not on any aspirin or statin and the patients end up having a deep or a non-lobar ICH, then there's no indication to start them de novo.
Any other questions?
Wonderful talk. Thank you for that. As you were describing, you've got common risk factors, right? Hypertension for an ischemic stroke, hypertension for ICH. Do you have any biomarkers, or have they found any biomarkers that suggest that a patient with chronic hypertension is more likely to have an ICH versus an ischemic stroke, or vice versa? And if so, wouldn't that be more compelling sort of evidence that a particular patient population is better served with antiplatelets and maybe another one not?
No, I think that's a very, very interesting question. And I think decades of research have gone into discerning who ends up having a lacunar stroke and who ends up having a deep ICH, because they're essentially part of the same spectrum of chronic hypertensive disease. A lot of investigations have looked at different cerebral small vessel disease markers. For a very long time, people thought that having microhemorrhages in the brain is a reflection of increased ICH risk, which many people still believe is still the case. There was a very big meta-analysis that came out in JAMA Neurology a couple of years ago, where they looked at all these different cerebral small vessel disease markers. They looked at microhemorrhages, prior lacunes, and white matter hyperintensities. And unfortunately, what they found was across the board, all these three markers individually were associated with both an increased risk of both ischemic stroke and intracerebral hemorrhage, and even cognitive decline and dementia down the road. So at this point, you can argue and potentially take the hazard ratios to and make a case, but simply put, I don't think there's a clear way in which you can say who's at risk for what.
Thank you. Any other questions?
Thank you very much.